Hello, I'm Dr. Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast once again, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes. And if you like what you hear, do please consider leaving a review to help other listeners find us. Now, you can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups, and you can find me on there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about the upcoming study group meetings which run throughout the year. Now, in this episode, I'm going to be discussing polycystic ovary syndrome, and this topic has been requested by one of our GP listeners. So do please send in any suggestions, as we do love to hear from you. Now, this was first described in 1935 when it was actually known as Stein-Leventhal syndrome from the two American gynecologists Irving Stein and Michael Leventhal, who had associated the presence of ovarian cysts with anovulation. Now, we know that PCOS is the most common endocrinopathy in women of reproductive age, and we also obviously know it's a well-known cause of complications in pregnancy and infertility. It's also associated with things like insulin resistance and metabolic syndrome, steatotic liver disease, and an increased risk of type 2 diabetes. Now, here in the UK, up to 1 in 3 women actually have more than 10 follicles per ovary detected on ultrasound, but only 1 in 3 of these have PCOS. And this is commonly defined as the presence of polycystic ovaries combined with the characteristic features such as acne, male pattern baldness, hirsutism, amenorrhea or oligomenorrhea, or raised serum concentrations of testosterone and or luteinizing hormone. Now, although we say it affects about up to 15% of women of reproductive age, this may in fact rise to 20% of women if the 2003 Rotterdam criteria is used, and I'll touch on what this is shortly. Now, the cause of PCOS does still remain unclear, but we do know it's multifactorial, and we think it's inherited as a common complex disorder. We know that in up to about 80% of women with PCOS, insulin resistance is present, independent of obesity, but this is further worsened by the excess weight that can be triggered by this condition. Levels of luteinizing hormone, or LH, are increased in almost 40% of women with PCOS, and as a result of continued exposure to estrogen unopposed by progestogen, the endometrium in PCOS may become hyperplastic. And we also know that testosterone is converted to estrogen in peripheral fat. Now, I mentioned the Rotterdam PCOS diagnostic criteria, and this allows the diagnosis to be made if other causes have been excluded, and 2 of 3 criteria are present, and these criteria are 1, polycystic ovaries, 2, oligo-ovulation or anovulation, and 3, biochemical and or clinical signs of hyperandrogenism. But having said that, the diagnosis of PCOS remains largely one of exclusion. Now, we know the common features include hirsutism, acne, scalp hair loss or male pattern baldness, irregular and infrequent periods, weight gain or difficulty losing weight, and infertility. And in obese women with PCOS, we also may occasionally see acanthosis nigrans, which is thought to be linked to increased levels of insulin resistance. But less commonly, we may see deepening of the voice, clitoromegaly, and increased muscle mass. Now, in all women with PCOS, we should always check their body mass index and waist to height ratio, as well as their blood pressure levels, because women may have elevated blood pressure with this syndrome. There are a number of differential diagnoses I would always consider, and these include hypothyroidism, hyperprolactinemia, acromegaly, things like Cushing's syndrome, and also iatrogenic side effects from medication that can cause hirsutism or weight gain themselves. And I'm thinking of things like danazol, high-dose steroids, phenytoin, and cyclosporin here. When we're investigating PCOS, we're looking at both endocrine tests and ovarian imaging. And we should always remember the three main endocrine abnormalities in PCOS here, which are 1. An elevated luteinizing hormone with normal follicle-stimulating hormone levels, 2. An elevated free testosterone level, and 3. Insulin resistance with compensatory hyperinsulinemia. Now, women with PCOS typically show a serum concentration of testosterone above 2.5 nanomole per litre and a serum LH above 10 international units per litre. I also think that fasting glucose tests or an HbA1c level are helpful in assessing insulin resistance, and prolactin tests can also exclude hyperprolactinemia. Don't forget thyroid function tests too, because thyroid dysfunction can present with oligo or anovulation, or irregular and heavy menstrual bleeding and weight gain. Now, ultrasound scanning obviously is used to assess for the presence of polycystic ovarian morphology, unless we think that the diagnosis is obvious on clinical and biochemical grounds. Now, ideally, transvaginal ultrasound gives higher resolution images of the ovaries than transabdominal ultrasound, with polycystic ovarian morphology being defined as the presence of 20 or more follicles in at least one ovary on ultrasound imaging. Now, a really important point to remember from this podcast is that polycystic ovaries do not have to be present to make a diagnosis of PCOS. And the finding of polycystic ovaries does not alone establish the diagnosis. Now, if we find endometrial thickening on imaging, then an endometrial biopsy is indicated to determine whether endometrial hyperplasia or even cancer may be present. Because of the possible long-term risks to health associated with PCOS, any woman with the condition should be informed of these, because obesity, dyslipidemia, and insulin resistance all impact on cardiovascular risk. And we should also be offering screening for impaired glucose tolerance and diabetes. Any woman diagnosed with PCOS should also be advised about weight control and exercise, because we know weight loss improves both fertility and pregnancy outcomes, as well as psychological symptoms and metabolic risk, even if the BMI remains above normal. There's also some evidence that a low glycemic index diet may be helpful, and any hypertension should be treated in the normal way, although there is no rationale to routinely use statins in women with PCOS outside of normal guidelines. Now, although there's a range of treatments available that we use for PCOS, there is no one single treatment which reverses the hormonal changes of PCOS or treats every clinical feature. And so, the medical management is aimed at the symptoms that are present in each individual. And one of the treatments, obviously, that we often consider is the combined oral contraceptive pill, the COC pill, provided there are no contraindications to its use, and we should be using this in the normal way, with the usual advice given to the patient about risks, side effects, and potential drug interactions. However, I would say that COCs with 35 micrograms of ethinyl estradiol plus cyproterone acetate preparations shouldn't be considered first line in PCOS because of the risk of possible adverse effects, including the venous thromboembolic risks. Now, if acne is a significant issue in someone with PCOS, then topical retinoids or antibiotics can be prescribed as appropriate. If hirsutism is a main problem, then hair removal methods should be discussed, but in general, the oral contraceptive pill is more effective for acne than for hirsutism in PCOS. If a woman with PCOS presents with infertility and would like to try to conceive, then the 2013 NICE guidelines advise that after weight loss, where indicated, and a full fertility workup, these women should be treated with clomiphene, metformin, or a combination of the two. But clomiphene does appear to be preferable to metformin for ovulation induction in obese women with PCOS. Now, we've all used metformin in our patients with PCOS, and this is used off-label. So consider seeking specialist advice. Now, the International PCOS Network makes the following recommendations on the use of metformin for non-fertility indications. It says that metformin, either alone or in a combination with a combined oral pill, may offer greater benefit in high metabolic risk groups, including those with diabetes risk factors, impaired glucose tolerance, or high-risk ethnic groups. Also, in addition to lifestyle measures, metformin should be considered in women with a body mass index of over 25 for the management of weight and metabolic outcomes. And if metformin is initiated in primary care, it should be explained what an off-label use is, and that adverse effects such as gastrointestinal symptoms and reduced vitamin B12 levels may occur. So, just wrapping this all up, PCOS is the most common endocrinopathy in women of reproductive age, as well as being a major cause of infertility and pregnancy complications. It includes symptoms of hyperandrogenism, the presence of hyperandrogenaemia, oligo or anovulation, and polycystic ovarian morphology on ultrasound. It's strongly associated with complications that may arise from it, including insulin resistance, metabolic syndrome, fatty liver disease, and an increased risk of developing type 2 diabetes. And the main aims of treatment are directed at reducing hyperandrogenism or to induce fertility. So I do hope you found that podcast helpful, but do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thanks for listening and goodbye.